Welcome, everyone. Thank you for joining us today. My name is Dr. Louise Ivers. I'm the faculty director here at the Harvard Global Health Institute, and it's my pleasure to welcome you all to HDHI's Global Health Research and Innovation Speaker Series. This monthly series, hosted by HDHI, is designed to showcase the latest advancements in global health research with the goal of fostering dialogue and elevating innovative solutions that advance health outcomes worldwide. Before I introduce our speaker today, I have a couple of notes. The session is being recorded through Zoom, and the recording will be made available on our website and YouTube page in the coming days. We're planning to have time at the end of the presentation to answer your questions. So if you have a question, you may submit it through the Q&A feature on the bottom of your screen. We'll do our best to get to those during the Q&A portion of today's event. So with that, please allow me to introduce our speaker today. Ole Norheim is a physician and the Mary B. Saltonstall Professor of Ethics and Population Health at the Department of Global Health and Population at the Harvard T.H. School of Public Health. He co-founded the Bergen Center for Ethics and Priority Setting in Health at the University of Bergen in Norway and is an adjunct researcher at that center still. He obtained his PhD in medical ethics from the University of Oslo. His diverse research interests include theories of distributive justice, inequality in health, priority setting in health systems, decision science, distributional cost effectiveness analysis, and how to achieve universal health coverage in low and middle income countries. He's the lead series editor of Disease Control Priorities and a member of the Lancet Commission on Sustainable Healthcare. Professor Norheim chaired the World Health Organization's consultative group on equity and universal health coverage and its technical advisory board on health benefit packages. I'm thrilled to have him here with us today, and it's my honor to welcome you and pass you the microphone. Thank you so much.
Thank you so much, Louise, and thank you for inviting me to talk to you all today about the ethics of priority setting in global health. And I'd like to start with optimistic message. I was recently part of a Lancet Commission on investing in health. It's called Global Health 2050. It was led by Dean Jameson and Lawrence Summers. And we were a big group of experts from all over the world looking at where to invest in health to improve population health globally. And we asked this question: is it possible to halve premature death by 2050? And the graph you see here is the probability of dying between age 0 and 69 on average for the world. And we are looking back the last half century. And the red dot indicates what would happen if it was possible to halve premature deaths as we have defined it by 2050. So you can actually see that the large, big trends in the world are quite positive. We will have to scale up investments in health, and there are large disparities in premature death, as we will soon see. But the big trends are positive, and we should remember we live in very difficult times, also for global health. But we have a lot of knowledge, we have a lot of successes in medicine, and if we decide to do so, it's possible to continue this very positive development that we have seen in global health. What we did in the Lancet Commission, we also looked at the 25 biggest countries and looked at the probability of premature death and the trends over the years, the last half century. And as you can see, there's been a lot of progress in many countries, and I've indicated here Ethiopia after the famine in the 80s, after the civil war with Eritrea, When peace came, they invested in primary healthcare, community health workers, and achieved a lot of improvements. Bangladesh investing in low-cost, high-impact services. Iran achieved fantastic progress, as did South Korea. So we found actually that 7 out of these 25 most populous countries had achieved a halving in premature deaths in the same time period as we now have up to 2050. But of course, there are inequalities. And the indicator premature death, I see it as a kind of a very simple indicator of life chances. Most of us can expect to live until we are 70. In Europe, around 11% probability of dying before age 70. So 9 out of 10 can expect to live until 70. While in Nigeria, more than 60% risk of premature death. Kenya, more than 50. In Ethiopia, still more than 40%. So there are huge disparities, of course, and these are some of the challenges in global health. But we concluded in the Lancet Commission that nations that choose to do so can achieve 50 by 50 by investing in the right interventions, and that include prevention, intersectoral policies, and healthcare. It is possible to achieve halving premature death. And the key word here is priority setting. And the definition of priority setting that I like is that priority setting is defined as a ranking of policies and interventions, programs, given resource constraints. We have to take resource constraints seriously, and especially now in the climate of global health. But we also need to define our goals. And what I will argue in this talk is that in ethics, there is a lot of agreement around 2 goals for health systems. It is, of course, to improve health as much as possible for the whole population, what we often call health maximization. But it's also a growing awareness, also among ethicists, of course, that equity, or what I like to call fair distribution of health outcomes, is also important. And these 2 goals can shape our thinking about priority setting. I want to start with a story. I worked a lot in Ethiopia on priority setting and ethics, having discussions with Ministry of Health officials, clinicians, nurses, patient organizations. And one of the experience I've had that really made an impression on me was learning more about childhood cancer in Ethiopia. So this picture is just an illustration of Fortuna, who was 14 years old and got leukemia. And what we know about childhood cancers in general and leukemia is that we have the treatment for leukemia in children. In the US, in Europe, about 8 out of 10 children with leukemia will survive after treatment, while in Ethiopia, it's about 2 out of 10. And this is because there's not enough access to treatment for childhood leukemia. There are barriers to access, there are wide health system challenges, but it also a type of injustice many of us will feel, that when a child is dying unnecessarily of something that she could be treated for, and we have that knowledge, it's a kind of injustice. And that is the first of a small list of ethical dilemmas I want to point to, because we have to take seriously that there is insufficient funding, even for very beneficial health services that people need. And I like to call this first order unfairness. So there are global injustices in access to care across countries. And this has become an even bigger challenge now recently, because we see cuts in overseas development aids and the willingness to be solidaric and argue for our obligations to support countries and people in low-income countries who are really in need of basic health care. I will not talk a lot about much more about this type of injustice, but more discuss then, given resource scarcity in a country like Ethiopia or other low and middle income countries, how to think about fair and efficient priority setting. Is it unfair that a child with leukemia don't get access to efficient treatment? So that's kind of a leading dilemma for me that I want to explore. And I'm not arguing that we have all the answers, but there's been some progress in our thinking around these issues. And the bigger picture here is in many ways that one reason why childhood cancer hasn't been really prioritized in Ethiopia is that still both the government and external donors and the international community have focused a lot on maternal and child health, and especially infectious diseases, and rightly so. And we have seen tremendous progress in this area. But because of this success, we now see that life expectancy is increasing. We get more older people also in low-income settings, and chronic diseases, non-communicable diseases, is becoming more of a challenge. So if we want to develop a fully modern universal healthcare system, we need to be comprehensive, and the system needs to cover all kinds of diseases and risks. So people also die of stroke, breast cancer, suffer from mental health, and so on. And there is no global fund to treat NCDs. So there is a dilemma here. Should we support, and should countries in low-income settings where there are still big challenges for infectious diseases and maternal health, how should they set priorities between these interventions and prevention and treatment of coronary heart disease, stroke, cancers? And these are some of the dilemmas that many countries struggle with. And I want to repeat again my definition of priority setting, because in some countries, there's extreme resource scarcity. So we need to think about the opportunity cost. Now, when countries might get cuts in their budget for HIV/AIDS treatment, they have to take over that responsibility. But that means that they cannot expand the services to prevent cardiovascular disease, for example. So that's why we really need to think about the goals and what is fair and efficient in these kind of hard choices. I often get the objection, and when we presented the Lancet Commission on priority setting and investing in health, people often asked us, why don't we argue for strengthening the healthcare system? And I'm the first to agree that we need, and countries need to strengthen their healthcare system. But as I see it, the message of priority setting is that at the program level, government decision makers have to decide whether to do more, invest more, improve delivery implementation of some services over some other services. And what I'm arguing that we need to set priorities. What many countries opt for is to give a little bit to everyone. So there's very low coverage for many services. And what we argue, and what is provocative in my view from the Lancet Commission, is that by focusing on a few diagnoses, the most effective interventions, we can achieve more than spreading the very scarce resources thinly out. So we give a little bit to everyone. This is, of course, very difficult politically, but I will argue that setting priorities is important. Another ethical dilemma is whether to invest more in primary care or in advanced hospital care. And here, I think all ethicists, all economists would agree it's more equitable, it's more cost efficient to invest in primary care. But politically, that's very hard because the elites expect, and many among the public expect to get advanced hospital care when they become ill. So politically, the political economy of priority setting, shifting resources towards primary care is very hard. And we need to take this political situation also seriously. And finally, the ethical dilemma that's being much discussed now is who should decide. These are hard choices. Priority setting in healthcare is difficult. We have seen in global health, the big global health initiatives, the big funds, the Gavi Alliance, the Global Fund to treat TB, malaria, HIV/AIDS, and so on, has dominated decision-making. And we see and we need a change in respect to who are making the decisions. I've listed several ethical dilemmas, and in 2014, I was asked by WHO, together with a group of ethicists, a human rights lawyer, and some health economists, to give advice to countries on how to make fair choices on the path to UHC. And universal health coverage is defined as providing everyone who needs health services with high quality care without financial risk. And of course, really expanding the range of services we have in a country to universal health coverage is almost impossible if the resources are extremely scarce. So I think we should see this as a progressive realization of universal health coverage. And we gave the following advice. I will summarize very quickly the kind of 3 key recommendations on how countries should advance, both to make services more universal, to reduce financial risk, and to choose the right services to expand. That is priority setting. And we argued that the first thing countries need to do is to set priorities. Countries have to choose which kind of services to start with, to expand services, to expand universal coverage, and to reduce financial risk. The second point is that when a country has set priorities, they should implement these services and expand coverage for these high priority services and make those universal. So for example, if giving safe birth is a high priority and heart transplants is not, countries should implement and make sure that giving birth with a skilled birth attendants is provided universally with no co-payment. That would also mean that for people needing a heart transplant that's not prioritized, they might have to pay out of pocket, or they might not access to this service. So these are the kind of hard choices, but that was the recommendation that we made. And then third, while expanding high priority services, make sure that the disadvantaged groups are not left behind. In this expert group, we also discussed a lot what kind of criteria and principles and goals we should recommend for priority setting. And at that time, WHO and the World Bank and many countries had basically recommended cost effectiveness analysis. This is a method where you measure the cost of an intervention and the health benefits in terms of survival and improved quality of life. And this is a method where you identify very cost-effective interventions, such as many vaccines, treatment for diarrhea, pneumonia, giving birth, are all cost-effective interventions. And we all agreed in this committee that maximizing health identified by interventions that are cost effective is an important starting point. But we also argued, and this was new at that time, that equity or fair distribution, or what we agreed to call extra priority to the worse off, is an additional criterion that's very important. So we defined the worst off as those with lowest lifetime health, or with low health and poverty. And the worse off can be defined in many different ways: the disadvantaged, the marginalized, people in prison, sex workers, people living in rural areas that are hard to reach. All these are dimensions of equity or fair distribution. But identifying those who are worse off, and my example of patients who are worse off compared to others are people suffering from mental health disorders. So, for example, take schizophrenia. Many patients die prematurely, and the quality of life is over the lifetime is substantially reduced. And we don't really have cost-effective intervention to treat schizophrenia. But from an ethical perspective and a fairness perspective, we also want to provide that type of care. So we need to balance the criterion of cost effectiveness and the criterion of giving priority to the worse off. So we not only use the cost effectiveness criterion. That was our recommendation. We also recommended a third criterion, financial risk protection, and that's part of the UHC definition. We know in many low-income countries that country might be pushed into poverty by paying out of pocket for services that they are not provided for free. So we argue that decision makers should also invest in health services that are effective, that are equitable, and that can also prevent people from being pushed into poverty. So these are the three criteria that we advise can help resolve some of the ethical dilemmas that I discussed initially. And we also recognize that there is legitimate disagreement both on the criteria and the proper balancing and weighing of these criteria. So we also advocated for open, accountable processes of decision making with inclusive processes, with transparency, and with reason giving. And we built a lot on Norman Daniels's approach, accountability for reasonableness. And this leads me to my two final points. Who should make these decisions? The Lusaka Agenda is an initiative by many countries, low and middle-income countries, especially in Africa, also involving processes with the global health initiatives. And the Lusaka Agenda is an important reform agenda now for trying to shift global governance to more autonomy, more freedom to choose, more control over budgets, more accountability at the local and national level. Decisions should not only be made in Geneva or in New York or in Washington, D.C. or elsewhere. Decision making should happen close to where the patients are and at the local and national level. And the second point is about the need for open deliberation, more open democratic decision making. So setting priorities requires hard choices. We need an open, inclusive process where also patients and citizens are involved in making these decisions. And that is important also for fairness and for legitimacy. And also mention another initiative. This is from a World Bank report published in 2023, broader on health financing in general, but priority setting and strategic purchasing is part of this. And in this report, we recommended open, inclusive processes, building on core principles of equality, of impartiality, of consistency over time, but also about the importance of inclusiveness, of participation, but also giving reasons for hard choices. And full transparency, accuracy of information, we need to build on evidence. So we need evidence-informed priority setting. We can also make errors, so there should be a mechanism of oversight, revisability of priority setting decisions and institutionalizing this type of accountability mechanisms. So what I've tried to argue, then just given you a snapshot of dilemmas in priority setting in global health and in low-income countries. It is inevitable. There are resource constraints that we need to take seriously. We can argue for more global redistribution, but there will be limited resources for the foreseeable time to come. And all these decisions have an impact both on the kind of the level, the improvement of health, and also the distribution of health and well-being, health and poverty, health and income, and so on. So we need to take into account, and I agree that a lot of ethics experts, some are utilitarians, some are egalitarians, but I think most of us agree that we should care both about improving health as much as possible, but also caring about fair distribution, and that in the implementation and making these decisions, open deliberative processes are very important. But by doing so, these principles and these goals can guide priority setting within health systems on their path to universal health coverage, which I think is still a very important goal and something that we should have in sight. So I will stop here and look forward to hear your questions and comments. Thank you so much.
Thank you so much. Thanks for giving us such a clear overview of your work and the type of work you're engaged in. I was struck by the sense in my own spheres of work that kind of a principled approach to ethics is not always how we engage. Like often it's drawing on your personal sense of morality, or and many of us have done a limited training in ethics, or we feel like we have different groundings. So this is very helpful. We have a lot of questions coming in, and I might start with one of my own. I mean, you described this in your closing comments too, and I think in your opening slides about first order of unfairness, which could be in some ways related to the massive global maldistribution of resources, and the responsibility that many of us, or some of us at least, feel in the global north, in North America, in Europe, for the economic situation that perpetuates in many countries we're speaking about. Like, how do you grapple with the practical realities of priority setting within the constraints of the global economic system with the ethical nature of, I think, what you were describing as the first order unfairness?
Yeah, thank you for that question. So I've always been motivated, I think, by global justice. I think many of us who work in global health have that as a kind of personal motivation. And I think at a personal level, being a doctor and seeing, I worked in Ethiopia as a doctor, seeing patients dying unnecessarily compared to what I have experienced as a doctor in Norway. I feel this kind of solidarity with patients, and I react emotionally that it's totally unfair. And I think this informs many of us. But at the kind of the philosophical level, there has been a discussion about the concept of global justice. And many philosophers, including John Rawls, for example, have talked about in the absence of a global world order or a world government, no one has the authority to redistribute resources. So it's up to each country to decide. And of course, there's a big debate about this. And if I think about Norway compared to the US, life expectancy in Norway is higher than in the US. So do we have a responsibility to allocate resources from Norway to the US? I don't think so, because the American democratic system have decided on one system, and we should respect that. That said, I think there are huge inequalities, disparities when I compare Norway and the US with Ethiopia, for example. So when basic human rights, very basic healthcare needs goes untreated, I think that's an appeal that go beyond this responsibility or this global justice argument. So in that sense, I think we need to work more mobilizing funds, thinking of solidarity, international solidarity, even in the absence of a global world order.
Yeah, thank you. So you mentioned about disagreement on principle, and you also spoke about open democratic decision making. And I'm curious, and we have a couple of questions about this. Do you have practical suggestions of how that can be done, or successful examples of how that has been done, where people really, community members, patients, etc., really have had an input into the process of prioritization, priority setting?
Yeah, I would say that priority setting, a pioneer country in priority setting has been UK, England, and United Kingdom, and they established this National Institute of Clinical Excellence. They have set up mechanisms for developing clinical guidelines, making decisions based on cost effectiveness analysis, and they always include patient organizations, have open hearing processes, and adjust their recommendations based on open hearings. And they very explicitly said that they were inspired and wanted to implement Norman Daniels' accountability for reasonableness framework. And a lot of European countries, the Netherlands, Norway, Sweden, has really tried to make priority setting a more open, transparent process. It's harder in many other countries, in more fragmented systems. It's harder, it's easier when you have a text-based system, a universal healthcare system. So I would say these New Zealand, Australia are also good examples. There are attempts in many low-income countries as well. We often see kind of stakeholder involvement, bringing people together to discuss issues, but I don't think it's so well functioning in many of these settings as what I've seen and experienced from UK.
Thank you. So let's say we have a scenario where we've had it at a national level in country X, in a low income country, priority setting, a degree of openness about that, so it feels well grounded in what the people of that country and communities want. You know, the resourcing of those priorities, unless you're talking about just the resources from within the country, are typically connected to some funder, whether that be, binational or multilateral organizations or foundations or such. Are you seeing a shift in acknowledging and respecting those priority settings? And if so, where, and if not, how do we get there so that the real priorities are the ones that are funded? And maybe this is a moment with the Lusaka agenda and the pullback from, the US and other countries. Is that a way to help move that forward?
Yes, I see a lot of these initiatives, and I think the Lusaka agenda has been very important in this respect. The Center for Global Development is now arguing for a new compact, so shifting power to local decision makers, and even shifting decision-making authority over donor, the use of donor money, and whether the big donors are willing to do so. I think that's a big question mark. The way kind of external aid functions is that the big donors will be accountable to their constituencies and they want to show results. But that is a problem for local decision makers because donors are often reshaping priorities. It might not be responsible to the needs on the ground. But I think that the Lusaka agenda, the initiatives from Center for Global Development and others, and I also see big funders like Gates Foundation, Wellcome Trust, they are pushing for this agenda. So this is a time, and of course with less funding, it might be an occasion now for using this crisis to change the structures. So in that sense, it could be an opportunity. It's incredibly difficult, but there is an opportunity and there is some willingness to change.
Yeah, I mean, interestingly, or maybe that's not the right word, the United States State Department Global Health Strategy, which was just published last week or the week before, is called America First. It's very focused. I mean, there are some aspects to it that I think many of us would agree are correct tactically, but the purpose is America First, global health security for Americans, a focus on infectious diseases, etc. So I think from that perspective, there's definitely a long way to go. But we have so many questions coming in. Thank you, everybody. I'm going to try to get to more of them.
Can I just comment quickly on America first? I think
Sure.
the ethical perspective is that we should think impartially, not about ourselves, but looking at who has a legitimate claim on scarce resources. And I think our thinking about global health should be ethically motivated, not only from a self-interested perspective, just to state the obvious.
Yeah, thank you.
Over to you again.
We had a couple of questions asking about conflict affected areas and conflict settings and how one thinks about priority setting in those types of environments. Is that a special case, or how do you consider those scenarios?
Yeah, I think that's a difficult question. I'm leading the Disease Control Priorities Project in a recent publication where we summarize experiences with setting priorities in low-income countries. We have a chapter and a report from Afghanistan and one from Somalia. And these are really kind of resource constrained, but also in a situation of conflict. And what we see there is that they had to rely more on experts working with extreme scarcity of resources and developing recommendations that would be more expert driven and less based on democratic decision making compared to other countries. We also have a chapter on Ethiopia. At that time, no conflict. It was before this civil war we had recently in Ethiopia, and we saw more attempts of opening up the process and involving patient organizations and professional organizations. But in conflict countries, this is especially difficult.
Thanks. I'm moving around quickly to different topics. You're kind of in the hot seat, but just because we have so much engagement from the audience. One thing that strikes me, and also has been a question from a couple of participants, is about cost effectiveness analysis and how, we don't always have a robust data that could even correctly inform a cost effectiveness analysis, even in its most expansive form. How do you think that applies from the ethical perspective as you're trying to make decisions maybe on less clear amount of data, or for countries that don't really have the information that's needed to correctly plug into those scenarios?
Yeah, so this is where I think research and providing these data and this kind of analysis is a global public good, and it could be an arena where really development aid could be spent that could be of use for all countries. But also, after I've said that, there's a need to build capacity and research within each country. So it's possible to collect these kind of data, and they are scarce. So it's important to invest in capacity building, and also we should acknowledge that there is a bias in all research, and especially on cost effectiveness evidence. We have a lot of evidence on certain interventions like vaccines, HIV, TB, and so on, multisectoral interventions, targeting mental health diseases and so on. We have much less data, much less information. There's less interest in doing this research. So we need to be aware of that. If we want to have evidence-informed priority setting, there are also biases in how this research and evidence is generated. So that's also why we need deliberation. We need wise decisions, not mechanical decisions based on data alone.
Yeah, a few questions are coming in about the practical applications of all of what you're speaking about, because it makes a lot of sense to do things in the way you've described in many ways. And then some questions are coming in about, for example, separating the political priorities from the actual real priorities. And what about in one setting where men's health is actually valued more highly than women's health. Or I was thinking myself too about rare diseases, very incredibly rare diseases. Do those weigh as priorities or not just because they're rare? Can you share a little more, maybe from your Ethiopia experience or other experience, some of the practical ways that you have worked on this so our audience gets.
Yeah, so many of us who work on priority setting, we are kind of facing this dilemma between kind of being technocrats and being truly democratic, and in a way, I think if technocrats could make recommendations and implement them, we believe it would be better. But of course, we want to strengthen democracy, and it's important that these decisions who affect citizens and patients, that they are compatible with their values. And also, recommendations on priority setting has to be aware of cultural diversity and how to respect different values in different countries. So I worked in countries where we recommend safe abortion services as part of essential services, but in a predominantly Muslim country, that would not be politically acceptable. So there might be a tension here between what I believe is the right thing to do based on my ethics, but we also need to be open, and that's why there need to be a political democratic decision-making process that's also contextual. So there are tensions here, and I could give a lot of similar examples.
We're coming close to the end of our time from this. We asked you to give us a whirlwind tour of the work, and we definitely have a lot of interest from the audience. But I wanted to turn to maybe your role as a professor now at the Chan School of Public Health. And a couple of students have been asking, and somebody's asked, how did you get your start as an ethicist in this world of work? And also, what are ways for students or early career professionals to get involved specifically in this? Do you have any advice for our audience members on that?
Yeah, so my story is that I studied medicine in Norway, but I was always interested in philosophy, and then I had the opportunity to do a PhD in ethics. And I read work by Harvard philosophers, John Rawls, Amartya Sen, Tim Scanlon, and I was very inspired by their work. So that's why I really went into this area on distributive justice. And I was motivated both on kind of understanding the challenges and the real world challenges, and being a doctor also looking for solutions. So I've always been interested in having this dual perspective on the world, both to understand but also to make a difference. And I think I meet so many fantastic students here at Harvard also who have this motivation to make a difference. And I will recommend people to really think through their own ethics now, especially in difficult times, what is meaningful for you and what you think is the right thing to do. And I think being clear about your motivations can also help you improve your work.
That's fantastic. I have a feeling you're going to have some folks reaching out to you after this talk because we have had a lot of engagement from our audience with a lot of questions. I'm sorry we did not get to them all. Thank you so much for this really enlightening talk. I really appreciate it, Professor Norheim. To our audience, please come back to the HDHI website and YouTube channel because we will be posting a recording of the talk. And we also plan to link in some references, some papers that Professor has mentioned, and we'll try to have some material for you all to be able to reference to as well. Thank you so much. Really appreciate your time today.
Thank you to all of you.